Hi, this is Dr. Wells with Wells Medicine, and I wanted to talk today about the misconceptions around treatment-resistant depression, or TRD, and some of the treatment options that are available. So, ketamine has mostly been studied for treatment-resistant depression. It's been studied for OCD, PTSD, anxiety, and severe depression, but most of the clinical trials on depression were in a specific sub-genre of depression called treatment-resistant depression. And when we talk about this, we need to have a clear definition of what psychiatrists mean when they say treatment-resistant depression. So there is no diagnosis of treatment-resistant depression in the Diagnostic and Statistical Manual, the DSM, which is where a lot of diagnosis codes come from. So it is a clinical diagnosis, and the diagnosis is based on major depressive disorder that has not responded adequately to at least 2 adequate trials of antidepressants from different classes. And each trial was at a therapeutic dose, taken consistently, and for an adequate duration. So that's at least 6 to 8 weeks of that medication at a therapeutic dose and taken consistently. So, for example, if you started Wellbutrin and they wanted to see how you did with Wellbutrin without a lot of side effects, then they might start you at something like 50 milligrams of Wellbutrin, but that is not a therapeutic dose. So a lot of medications are often ramped up to a therapeutic dose, but that ramp up time would not be considered treatment at a therapeutic dose. So it's only the amount of time that you are at a therapeutic dose for 6 to 8 weeks on that medication. If you've taken a medication like Prozac or Paxil and stopped it early because it wasn't working, so a week or 2 weeks, even 4 weeks, and then tried a different medication, that doesn't classify as treatment-resistant depression. And then they want to see that it's at 2 different classes of medications. So not just an SSRI, but also trying an SSRI and then separately trying an SNRI or an atypical or an MAOI. So if you've tried 2 different SSRIs, so Prozac and then a trial of Paxil, that doesn't count towards diagnosing treatment-resistant depression. So it's this very narrow diagnostic criteria of 2 different classes of medications, each for 6 to 8 weeks at a therapeutic dose. Often we'll have patients who come to us with this diagnosis of TRD or treatment-resistant depression from their mental health professional, whether it's a therapist, a psychiatrist, psychologist, or their primary care doctor, who are just giving them this diagnosis after having tried multiple medications, not necessarily for the adequate amount of time or the 2 different classes, or at the adequate dose, which is not necessarily the clinical definition of treatment-resistant depression. So I find that a lot of patients receive this diagnosis without actually meeting the criteria for this diagnosis, and then they feel even more broken, more unable to be treated. And it's very difficult to then try to work with patients on the fact that there are treatments, there are medications that can be helpful. They just haven't been tried on those medications yet. A lot of patients, when they're given the diagnosis of treatment-resistant depression, feel like this is a diagnosis that means that their depression is resistant to medications. But when you're looking at any of these classes of medications, SSRIs, SNRIs, atypicals, each of those classes of medications usually only is effective for about 30% of patients. So even though a patient may not have success with 2 different classes of medications, that doesn't mean that their depression is somehow inherently worse or somehow inherently more difficult to treat or somehow a more serious diagnosis. It just may mean that they haven't found the correct medication yet. And a lot of patients end up falling into this treatment-resistant depression category because, again, when you're treating someone with an SSRI, two-thirds of patients aren't going to see benefit. And a lot of times, even when the medication is starting to work, the side effects of the medications are so troublesome that they'll swap them to a different medication anyway. And then we really haven't gotten a chance to see whether that medication would even be able to be effective because the side effects are so troublesome that they had to stop that treatment course early anyway. I find that this diagnosis often is very difficult for patients to hear, but it doesn't mean that their depression is worse than other depressions, just that we haven't found the correct medication yet for them. So at Wells Medicine, we often see patients who are sent to us for treatment-resistant depression who have been battling with depression, particularly a single episode of depression or multiple episodes of depression over many years, and have tried many different medications, many different classes of medications, many different adjunct medications. Some have even tried electric shock therapy, ECT. Some have already tried TMS. Many patients have already tried several different forms of therapy over the course of many months or even years. And often it's just a matter of finding the correct treatment or series of treatments or holistic grouping of treatments that can be really helpful in alleviating this episode of depression. Often there are still really great solutions out there, and it takes an open mind and an open heart to look for those solutions and to work with patients and find maybe slightly more complicated or maybe slightly more original or unique solutions, but that there are still solutions out there. And often it just means that maybe the obvious ones don't work, but that there are definitely still things out there that can be helpful, including ketamine, which has been studied extensively in treatment-resistant depression and has been found to be effective in 60 to 80% of patients with treatment-resistant depression. I really want to encourage patients who have been diagnosed with treatment-resistant depression to continue looking for treatments and to continue to have hope that there are things that will alleviate your depression.